Good afternoon again, everyone. And the floor is now open for any questions, clarifications, or insights with regards to the topics discussed by our two experts, Dr. Amato and Dr. Napplika. So the floor is now open. Please feel free to ask a question. You can open your microphones. There's also a microphone at the back. For those who are in our audience staying at the back, you may approach the microphone and ask the question yourself. So again, any first takers? Please feel free to use your own mic. Yes, Dr. Faisal.
Yes, thank you. I'm asking just starting discussion. So because I think this is the best time to Pro Amato. I'm interested in that your results. The first is there is no complication with barotrauma with recruitment maneuver. Because my experience, maybe we have a different population in Indonesia actually. From my side and my friend, some patient we have some complication like barotrauma exactly. Maybe we want to know how is your management or strategy that you did in the recruitment maneuver. And then I agree with Napplika said that we have to know what the population possible to recruit. And then, but the problem is when to maintain after we know the like the plateau, the PIP, ideal PIP, and the drive and pressure, and until the maintain the patient 24 hours and next, and the second or third day we found some barotrauma. Do you have any comment?
So, everyone that was dealing with COVID saw at least one patient like this, right? Pneumomediastinum, or even some cases like this, right? So, a hypertensive pneumomediastinum and emphysema subcutaneous. This was, in fact, they measure. Look how many papers about this. They measured at least 5 times higher incidence than conventional ARDS. And then the key question is, what is special? And then some people was talking about, oh, they have a more fragile parenchyma. Absolutely false. No, not the case, because my experience is exactly like yours. Pneumothorax is not in the first day, it's later on. Look at this. First of all, most cases of pneumothorax or pneumomediastinum happen during high flow nasal cannula, no mechanical ventilation. So COVID is blue, ARDS is yellow. So even during high flow, they have much more pneumothorax. And many of them, they happen after 10 days. Even during mechanical ventilation, also it's very few of them happen in the first day. So many of them, it's after assisted mechanical ventilation. So, and then, which is the reason for this? And the reason, I believe, is in this slide. The slide here is the following. So this is the response of volunteers. This is the alveolar PO2. This is minute ventilation. And this is the curve for volunteers. So we have a very bad ventilatory drive related to hypoxemia. Why? Because we only respond when PO2 is below 60. From here to here, there is almost no response. At least this is common in the normal population. But what they found is that COVID patients are like this. Not only this, they are like this. which means that they have very high ventilatory drive, much higher than common ARDS. And this happens for many days, which means that typically the problem is that barotrauma is related to the fact that they are under assisted ventilation. Is when they started to make efforts on top of mechanical ventilation. It's not our recruiting maneuver. Is what they are doing later. And something that this is interesting. Look at this slide. This is a patient, 70% of FiO2, and here saturation was 94%, okay? So someone is going to change. Let's see, just P.1 is 1.4, okay? 1.4, P.1, minute volume 9.3. Now we are going to change FiO2. 1 second, to 40%. And the saturation was now 90%, not hypoxemia, so 90% saturation. Takes 4 breaths. Now look at the next breath. Oops, double cycling. Now tidal volume is increasing. Look, it's almost 500 mLs. Minute volume is already 10, so respiratory rate increase. This is signal of expiratory muscle activation when you see this bump. This is expiratory muscle activation. Minute volume is 12. Tidal volume is 500. 13 of minute ventilation. Let's see P.1 now. 6.7. From 1.5 to 6.7 just because we changed FiO2. And this is happening in many patients with COVID. And then we are afraid about using excessive oxygen, but then we forget that these patients, they have a very high ventilatory drive. And then what happens is that it's very easy for them to do, like I say, self-inflicted barotrauma. It's ventilator-induced lung injury. And this is why I believe that most of the COVID patients, they have barotrauma when they are starting to do spontaneous ventilation. And we have to be aware about this. And typically, and also something that I really ask you to pay attention, minute ventilation. Because typically, sometimes we look at the patient, we see 15 liters per minute of minute ventilation. This is normal. It's never normal. 15 minutes, you are not doing protective ventilation because it's the combination of driving pressure and respiratory rate that matters. So if you're having a high minute ventilation, it's a signal that you're causing a lot of injury and this patient has a very high drive, and then maybe you should be changing your sedation, changing something, or even the FiO2. You can play with the FiO2 and check. It's not all patients that are sensitive to a change in FiO2, but at least 30 to 40% of them, they calm down the ventilatory drive if you give a little bit more of oxygen. Okay, this is, so I believe that the many cases of barotrauma were related to the ventilatory drive and not to ventilator settings that the physician adjusted. But then you have to understand, is it safe to keep a high PEEP level or not? It depends pretty much on each patient. Something that we know nowadays is that just because you are laying down on the bed, you may have decubitus atelectasis. And then, because remember that we needed high PEEP even in patients with normal lungs during anesthesia. So just because the patient is lying down, some patients, because they are obese, they need 15 of PEEP, which means that we are not doing the same strategy as before. For instance, in the old times, when we reached a FiO2 of 40%, we would decrease PEEP until 5 and then extubate. Now we try to reduce just gently the PEEP at the end, but no less than 10 centimeters of water. And then we extubate directly. Because we put the patient under CPAP of 10 and then we extubate. Because under this way, when the patient is extubated, he doesn't have remaining atelectasis. But you have to pay attention that we are not using pressure support of 5 plus 10 of PEEP, because then you are helping too much the patient. I'm talking about a patient that he's ventilating on CPAP of 10. And then you extubate under non-invasive ventilation with the same CPAP level. And using this strategy, we were more successful in having the patient free from oxygen.
Questions from the floor? Please feel free to ask questions. Yes, doctor.
Hi, I'm an intensivist from the south of Thailand. So my question is about when you decide to paralyze or not paralyze a patient, how would you quantify, I guess, the contribution of spontaneous breathing to compliance?
Oh, this is a very good question. Let me see if I have a slide here about this. Let's discuss this topic. So, this is a special study that we are doing, and some features for the future in electrical impedance tomography, that we are using artificial intelligence to estimate esophageal pressure. Okay, so in yellow you have esophageal pressure, so it's the total muscle pressure. So this is airway pressure, this is flow. Here again we have the airway pressure, and then here is the muscle pressure. So how much force the muscle is doing. Let's see how it works. So we are in the same scale here. It's a scale of centimeters of water, okay? This is pressure support level. So you can see that the breath was triggered by the patient, that started a little bit before, right? And this is the muscle pressure. In this case, we can see that the muscle pressure is 20 centimeters of water, and pressure support was just plus 10. So in this case, the total driving pressure is 30. And when I see a situation like this, I know that I have to do, I'm much more concerned with the yellow component than with the white component. And then in this case, I would think about, for instance, let's give a little bit of propofol. Okay, let's think about another case. Oops, sorry. Let's think about this other case here. Oh no, this is the same case. Now think about this other case. So now I have here the muscle pressure, and this is the airway pressure. So in this case, muscle pressure is 10 and airway pressure is plus 15. So in this case, the effort, I like when the effort of the patient is between 5 and 10. And then in this case, the physician was doing too much assistance. And then in this case, I would just reduce the level of pressure support. Okay? In this case, it was assisted pressure control ventilation, but pressure support would work the same. So the key question is how, in this case I had artificial intelligence to measure and I had a EIT, but how to measure this at the bedside? We are doing lots of studies together with Ewan Golliger from Canada, And I strongly advise now to use the expiratory, the P occlusion. And why this? Because we realized that measuring P.1 doesn't work very well. Why? Because we have too much acquired weakness in the ICU. And then what happens is that when you have muscle atrophy, sometimes your P.1 is high, but the effective pressure, which is you measure by P occlusion or by artificial intelligence, is low. So then, for me, the priority is to protect the lung. And then if the effective muscle pressure is low, I don't care. And I realized that P.1 is not good for lung protection. So then we use P occlusion. We use that kind of multiplication factor, which is 0.75 to measure P occlusion. So in this protocol for COVID patients, we are measuring P occlusion every single day. And we confirmed that the P occlusion was working because we paralyzed the patient many times to confirm that we are really measuring the driving pressure in the proper way. Now let's just go, now that we have this introduction, let's just finish with that slide, which is this one. So the global strategy is to avoid a high driving pressure, but you have to remember that the total driving pressure is what you set on the ventilator and what the muscles are doing. Something very interesting, and I like this approach, is to know how much compliance the patient has. Because then, and this is something that we did in the protocol, every single day we measure compliance in a condition that the patient was paralyzed. I like to use succinylcholine because it's very quick. And then if you know compliance, you can just divide tidal volume by compliance. And then I set the lowest pressure support, or in fact, I titrated pressure support, because sometimes with 5 of pressure support, I had a lower tidal volume than at 0 pressure support, because the patient was a little bit more comfortable and then was having a lower tidal volume at 5. So I titrated pressure support to give him the lowest possible tidal volume. From 15 of pressure support, I go down to 0. And sometimes many patients I kept at 0. It was the lowest possible tidal volume. So first. Second, never stay, if you are under assisted ventilation, your pH has to be under control. It's impossible to have a calm patient if he has acidosis. So even if you have permissive hypercapnia, you have sometimes to give a little bit of bicarbonate for him to have a normal pH, because then he can relax and having a lower drive. So FiO2, I have showed you the example. So sometimes I titrate. In how much percent of the patients this works? 1/3. So in some patients they have really a high drive related to FiO2. PEEP. To optimize PEEP can reduce your drive because of the Herring-Brauer reflex. But if you are above the ideal PEEP, you are going to increase the dead space, and then the patient is going to increase the drive again. So, but you have to test. Sometimes I try to increase a little bit the PEEP and the patient calms down. This is especially true during non-invasive ventilation sometimes. So sometimes you have just to test and check what happens. But you have to keep an eye always in the tidal volume. If you increase PPR, your tidal volume increases. Again, it's a signal that maybe I have increased dead space, higher PCO2, and then when nothing of these works, then I give more propofol. And if nothing works, even with propofol, I do partial paralysis. And partial paralysis is something that it's very tricky. because you are always afraid that the patient is awake and you are doing partial paralysis, right? So then I propose two things that have been very helpful, and we are collecting data to show that no patient remember about the partial paralysis, which is extremely important. And what we are doing is that for every single patient we use the BIS, and I use a parameter that is very, very, very precise parameter, which is respiratory rate. Suppose that you are under pressure support and your respiratory rate is 15, okay, 15 respiratory rate, but you measure occlusion pressure and the occlusion pressure is 30. I can tell you for sure, in this patient, giving more propofol is not going to work. Whatever drug to sedate more this patient is not going to work. What you have to do in this case is to set to partial paralysis. And then you can think, oh, but then, and what if the patient is awake? If the patient is awake, the first signal is that he's going to increase his respiratory rate. But if the patient stays with a low respiratory rate, you are 100% sure that he's not awake. So respiratory rate is a good signal for you to titrate. When you have already a low respiratory rate, but it's still a very high drive, then I give partial paralysis. But for instance, let's suppose the same thing. Occlusion pressure of 30 and respiratory rate of 30. Then I give more propofol. And then this is the rationale. So respiratory rate helps you to give either a little bit of paralysis or propofol. And it's interesting because we are collecting data now that we are giving less sedation when we started to do partial paralysis. Because in the past, whenever we had a high P occlusion, we would give more sedation, and it was not working well. And then having this partial paralysis allows you to give a little bit less sedation. And there is something interesting, is that we are collecting data about ICU acquired weakness. And we could show that there is correlation with days of sedation and days in the bed, but not with curare, with paralysis. Interesting. So it's the first signal that, okay, maybe paralysis is not the culprit, is not the bad thing. The bad thing is sedation and the number of days in the bed. It's very preliminary, but it's something that is being investigated. That's it. Yes?
A tiny question. Do you
Please?
usually see any compliance loss when you switch to paralysis compared to pressure support ventilation?
Ah, this is a very good question. Okay. Okay. This is this paper I mentioned before in the presentation, Respiratory Drive, and it's a very nice paper. And this paper is showing here something that is very interesting for us to understand. So this is PCO2. This is respiratory rate. This is tidal volume, and this is minute ventilation. Okay. So look at this. They are telling us that there are 3 phases. 1, 2, 3. So what is the first phase? Okay, PCO2 is normal. Then PCO2 is increased, and then look at this. First you increase tidal volume, but the respiratory rate is low. And then you cannot increase tidal volume any longer because it's not, it's very costly energetically. And then you start to increase the respiratory rate. So there are 3 phases. So every patient is like this. So you first increase, you get more dyspnea, you get a higher ventilatory drive. You first increase tidal volume, and then you increase the respiratory rate. This is why We see many times a patient with respiratory rate of 18, but a big P occlusion. Okay. But look, somehow in the middle here, from this phase to this phase, you start to have expiratory muscle activation. It's what happened when we run. You start to have a little bit of fatigue of the diaphragm, and then to help the diaphragm, you contracted the abdomen during the late exhalation, because then you go below FRC, and then you gain, like a slingshot, you gain potential energy for the next breath to have some tidal volume without doing any force with the diaphragm, just because you are relaxing the expiratory muscles. Just for you to understand how beautiful it is to see this with EIT, look at this curve on the top. This is tidal volume, and then we gave a shot of paralysis. Tidal volume decreased. But look what I see in the EIT. I see that the inspiratory tidal volume was here and then decreased, but I see the expiratory tidal volume was at this level here and increased. So this can only represent one thing, is that every breath I was overpowering my diaphragm to go up to here, and then this is the relaxing volume, and then at this point I activated the abdominal muscles to go from here to here, and then my tidal volume gets larger because I'm using both. Exactly, exactly. If your patient is like this, you paralyze him, and you are going to increase oxygenation. And vice versa. If you put this patient under assisted mechanical ventilation, he is going to antagonize your PEEP, and then he's going to drop oxygenation. So it's extremely important to access if the patient is using expiratory muscles, because then he's going to deteriorate. We are now doing, this is a study that is going to appear in the critical care. We are classifying the patients based on this response. You give paralysis if it goes up, which is a signal that he was activating the expiratory muscles, or let me show you the two examples. Then I come back to this. Okay, this is a patient that I showed you. You paralyze. Look how beautiful it is. You paralyze, the end expiratory lung volume increases, right? And look at the esophageal pressure. It decreases. It goes like this. So, end expiratory esophageal pressure. This is during spontaneous breaths, and this is during paralysis. So esophageal pressure goes down because abdominal pressure goes down, and lung volume goes up. So this patient is counteracting 5 centimeters of water of PEEP. And this is what you should expect. You paralyze and you lose a little bit of volume. So this patient is the natural response, and this patient goes very well during assisted ventilation. And this patient is a very good patient to keep on pressure support. And you see the esophageal pressure is sustained. No increase in end expiratory esophageal pressure. So he was not using expiratory muscle. This is a new problem in the ICU. It's something that we are paying attention, that many patients deteriorate and you didn't know why. And now we understand that this is the problem. How many % of the patients? Is half and half. Half and half. So half of the patients, they improve during spontaneous ventilation, and half of the patients, they get worse. This is very tricky, huh? And look at this. The increase in end expiratory lung volume is related to the fentanyl dosage. So the more fentanyl or more opioids you give to the patient, more likely he's going to be in a bad shape during spontaneous ventilation because of this. So it's a new problem. We need new solutions. I don't know which, but something that we learn, this effect is antagonized by propofol. So giving a little bit of propofol makes it, so every time you're giving opioids, you have to at least give some propofol together. Then it helps. Opioids alone with benzodiazepines, for instance, it's terrible. Okay, so this is something that we are learning now.
To her first question, some ventilators don't allow to do the expiratory occlusion maneuver during the spontaneous breathing. What do you recommend to monitor PMAs? Which technique we can use in that condition?
For instance, there is some ventilators, like for instance the PB ventilator, doesn't have the expiratory pause during spontaneous, but you can do the NIF maneuver, negative inspiratory force, and then it works as an expiratory pause. It's just a little bit. You have to go through different. Try to find in your ventilator. If you don't, we do a video call and I show you the steps. But there is a solution. In this ventilator, you have both, so it's easy to do. Servo is very easy, and new ventilators, they are trying to have both. But typically, when you cannot do P occlusion, you can go the NIF, and then it works in the same way.
Questions? Go ahead.
Yeah, I'm Dr. Sonchai from the Bangkok Hospital. I just want to make sure I understand both Dr. Napplika and Dr. Amato correctly. So when you do recruitability assessment, you paralyze the patient, right? You don't do it on the patient to spontaneously breathing, right?
Yeah, you know, we tried before doing in spontaneously breathing, and there are some publications that are successful, but then I saw one single case that was a warning signal for me. And the problem is the following, is that the patient, if you give a little, obviously the patient has to be with a light sedation, right? And then you can do a kind of recruiting maneuver just playing with PEEP. The problem is the following. Certainly you have to be under pressure control or pressure support, because if you are in volume control, it's a disaster, right? Right. But then the problem is that sometimes the recruitment produces cough, and then you have a very deep cough, and then this can explode the lung. So this is why I always paralyze, because of the cough. Let me give you one example what is cough. So this is the plethysmograph signal in the EIT, and then this is a cough, and then lung volume goes down. So the problem of cough is not, and look how much you see this bump in the expiratory flow. So lots of volume are going out of the lung. So because you are contracting very strongly the abdomen, right? So the problem of cough is not here, is what follows here, because then you are going to be at a low lung volume. This is going to produce a sensation of dyspnea, and you are going to take a deep breath, and then you have breath stacking. This is when you explode the lung. So typically cough is followed by breath stacking. And then you have a huge tidal volume, and this is when you explode the lung. So this is why I now, to do a recruiting maneuver, I paralyze the patient. And if you are concerned about acquired weakness, I recommend you to use succinylcholine. I love to use succinylcholine because it's very short, 15 minutes, and the patient is back to the same mode of ventilation. I even don't change the sedation or anything, or maybe I give a small bolus of propofol during the paralysis, but I like very much.
Okay, and talking about sedation and paralysis. I just want to ask a little more questions. You mentioned bees. Yeah, I'm not sure in Thailand we use bees in ICU very often. Even in my hospital, which has many bees, but we still don't have enough. I don't know about Chulalongkorn. But in Brazil, you use it in every.
I
patient.
think at least if you are thinking about doing partial paralysis, you have to, because and something maybe this is correct because we know that the BIS is not a 100% specificity device, right? But it especially works for propofol, and since in this case I like to use propofol as the main sedation, it works very well. So I typically try to keep it around 60 to 70 maximum during partial paralysis. Ideally 60 or less.
And when you say partial, what do you mean by partial?
Good point. Good point. Excellent. First, I was imagining, no, let's use all the technology we have. So let's get a device for measuring the train of 4 and measuring the degree of paralysis. And then I realized that the best parameter is P occlusion. Because, you know, the train of 4 can be completely down, so you have 0 response, but you are still having a high P occlusion, because the diaphragm is a little bit more resistant to paralysis than the rest of the muscles. So the best parameter is the P occlusion. So you titrate P occlusion, and then you stop there. Something that I learned by myself, because there is no textbook or article to tell you about this, is that Rocoronio doesn't work very well. And I know because in my hospital is the most used agent for paralysis, Rocoronio. But Rocoronio, I don't know, understand very well, because you are using, and then slowly the patient at the same level, and slowly the patient gets completely paralyzed. And then you remove, and then suddenly the patient is back to doing a very big force. So it's not stable. And then we started to use cisatracurium. Then you typically find a very nice spot, precise dose that you titrate. Oh, P occlusion now is 12. I'm going to increase 1 ml per hour, and then gets to 10, and then I feel happy about this. So it's very stable doing with cisatracurium and measuring P occlusion.
Maybe my last question. So all of things that we talk about are about patients who are supine. Then what happens when you flip the patient? What is the driving pressure that you would use? And would you do recruitment maneuver in prone position patient? And a little bit extension of my question is on ECMO.
Wow. This is a lot of questions, but very important questions. Very important. Very important. So, let me show you some more slides here. First of all, remember that I told you that when you titrate PEEP using EIT, I always choose the crossing point between collapse and overdistension. Okay? Why this? Later on, maybe we have some time to discuss, because this typically produces the optimal transpulmonary pressure. We have now lots of studies showing that when you choose the crossing point, your transpulmonary pressure is +2. That is exactly what every normal lung, or even the diseased lung, they feel more comfortable. Later on, maybe I come back to this point, but this is exactly something that they realize in the EpiVent study, they did a post hoc analysis in the epivent, and they realized that all the patients that used a transpulmonary pressure close to +2, they had the best prognosis. And if you have super obese patients, to be at a slightly positive transpulmonary pressure, you have to use a very high PEEP, because this is patients in Boston. But anyway, we always choose this. You said so because you have a little bit of overdistension, and you have a little bit of collapse already happening in this lung, but is the, let's say, the happiest condition for this lung. Let's go now. This is the model I use in my lab to produce obese patients. I just put some weight on the abdominal cavity. Okay. What happens with the EIT signal? This is without weight. Collapse, overdistension, crossing point at 5. Now I'm going to put the weight, and the curve moves to the left. So collapse starts at a higher pressure, overdistension. I don't see any overdistension here because the weight is protecting. And I have exactly the same peak compliance. So everything is just shift to the left. So going back, look, this is a patient normal, and now with the weight. So it's just a left shift of the curve, okay? Now trained Allenburg. 11 goes to 16. So trained Allenburg is equivalent to putting some weight on the belly. And now, the most important thing, what happens in prone? In some patients, 14, 21. So this particular patient, he had a very prominent belly, and when in prone, he had a big, let's say, compression of the diaphragm because of the abdominal content. And then to stay in a good oxygenation and a good PEEP without the crossing point, he needed 20 of PEEP, while in supine he needed only 12. So it's a big difference. Oh, but this is for all patients? No. Some patients is the opposite. Some patients, they have more overdistension in prone, which means that they need less PEEP. So, in general, patients need 2 centimeters less PEEP in prone, in average. But each patient should be individualized. You can be 100% sure that when you prone a patient and the patient deteriorates, it's because you have something like this. It's a patient in which the belly is compressing the diaphragm, and then he needs higher PEEP in prone. Okay? So after learning this, what do? We titrate PEEP again in prone. So we titrate in supine, and then if we prone, we titrate again in prone. But let me tell you another trick that I think for me was the most important one in clinical practice. This is a patient in supine. So you know that patient has dorsal collapse. How do you know? How do you know when you see an image like this? This is the typical image in EIT of a patient with dorsal collapse. You see, the ventral to dorsal ratio is very low. Sorry, it's very high, which means that I don't have dorsal ventilation. So this is a patient that I know that has dorsal atelectasis. Okay? So let's go back. So you have a patient that you know he has dorsal collapse. Then you're going to prone. What do you expect is that along the hours you are going to have some dorsal recruitment, maybe this, and maybe this. Certainly there is a shift of the collapsed zones, and then you are starting to have some ventral collapse. Now you have a problem. is that I'm going to supine this patient again, and you must have this experience with COVID. I remember that with COVID, some patients, they had 8, 10 sessions of prone, because every time we are supining the patient back, the patient deteriorated again, right? And then we realized something very interesting, that there is a trick that you can do here, which is now you just apply +4. So if the patient is obese, you apply +6. And now you start with some ventral collapse, which is going to reopen, and now this extra PEEP is enough to avoid the recollapse of those zones. And it works very well. And then we also did this because, can you look at me? When the patient was prone, and then when I was resupining the patient doing this, I could see when I used the EIT that this side had more collapse than this side. So only just resupining the patient and putting him in lateral position, and then, so this side here gets more atelectasis than the other side. And then and then using this maneuver, you avoid this. And this decreased a lot the need of a next proning maneuver for this patient. So this was something very interesting. And this was also something that improved my understanding about prone. Because the key question is how much time you need to go from this to this. And this needs a recruiting maneuver, or is going to happen spontaneously? This is an important question. Okay, let's move on. Okay, look at this. This is this CT is from Luciano Gattinoni. Okay, this is a very old CT from Luciano, the first time that he was describing proning. And then he showed that this collapse is migrating. Migratório in Portuguese is migrating collapse. So from dorsal to ventral. The key question is how long it takes and how it works. So we started to do some pig studies. This is the animal in supine. Sorry for the quality of the CT, it's very bad, but there is lots of collapse here. And in prone, 10 minutes after prone, it's still full of collapse. So only, we can see here in the histogram. I'm running out of battery. But you can see in the histogram that there is, look, lots of units, they have the density of collapse. And then only 24 hours later, I got rid. So in this animal, it took 24 hours to reverse. Ideally, now, every patient that is in prone, I like to use EIT because then I put the ventral and dorsal platysmogram. And then this is ventral, and this is the dorsal. And you can see that the dorsal is increasing along the time. Which is the meaning of this? You are gaining aeration. And ideally, you should see gaining aeration and decreasing driving pressure along the time, which is the yellow. So we are following this very much because this is the ideal response in prone. You should always see this. You have to gain aeration, meaning that you are reversing the atelectasis, and you have to see a drop, a progressive drop in driving pressure. So this is the whole night, okay? This is the whole night. Takes the whole night to happen. But some patients, they do this very slowly. And what you have to do? Keep going. So now there is a paper published in Chest. Let me see here. This paper, published in December 2022. Prolonged prone position reduces mortality. Which is prolonged? More than 24 hours. And I don't think that this is for all patients, but it's for those that you see a very slow response. And then you know that it takes a long time to reopen the atelectatic areas. So I'm enjoying the prone position more and more because it's one of the best recruiting maneuvers. And so this is why I never use any more than 45 of recruiting pressures, because if I don't recruit everything after achieving 45, I prone the patient. Okay, so there is no need to go up to 60 as in the past, because if you go to 45 and you don't achieve a good result, let's prone. But it's still, I still strongly believe in the idea of using the recruitability test, because it gives you a flavor if it's worth it to go up to 45.
Doctor, we have a phone-in question. Actually, we're also live. So we have someone asking, what do you think of lung recruitment maneuver for ARDS patients on ultra-protective lung strategy?
Yeah, and then this comes back to his question about what about in ECMO. Yeah, I think the ECMO patient is the patient in which recruitability and recruitment is the most important one. Why? For two reasons. First is that these patients are the sickest ones, and they have the largest amount of lung collapse. The second reason is that the lower is the tidal volume, the higher the chances of having reabsorption atelectasis related to low VQ units and high FiO2. So even if you are not using high FiO2 in the ventilator, if you are using the membrane, this also promotes some reabsorption atelectasis because there is no nitrogen in the blood. So reabsorption atelectasis is very prevalent in ECMO. And when we did it experimentally, every single animal that we put on ECMO increased the amount of atelectasis. Okay, then I'm a stronger believer in the idea of using open lung during ECMO. And I think it's interesting because the literature on PEEP for mechanical ventilation is very controversial, but in ECMO, every single meta-analysis show the same. The higher the PEEP, the better the ECMO results. So this is why today we never use 10, 10, 10. So you should 10 of PEEP, 10 of respiratory rate, 10 of driving pressure. We always use at least 15 of PEEP. But then to use more than 15, I prefer to titrate and check how much PEEP I need. Okay, this is for PEEP titration. But let's suppose that I do a PEEP titration in ECMO and my patient is still like this. I could not reopen the atelectasis. Then I'm going to prone in ECMO. And guess what? There are now 3 studies showing that the patient has to be prone in ECMO in the first 48 hours. And this improves the prognosis. Let me show you one study. Look at this. This one, prone position monitored by electrical impedance tomography. And then there is a French study and there is another French study. The 3 of them are showing that if you prone the patient in the first 48 hours, this is going to be much better. Okay, there is this other study. Let me see if I have here. One second. Oh, I don't, but there is an English study showing the same thing. If you prone the patient in the first 72 hours, this is going to improve in the first 48 hours. So now in my ICU, the nurses already know. if the patient is ecumo, he's going to be prone every single, which is a disaster, right? Have you seen the pronation procedure in ecumo? Ah, it's a nightmare, but it's feasible, and this is why. If I don't have a good blood flow in ecumo, I ask the surgeon to change the cannula, because if you have a bad blood flow, you cannot put in prone. That's it. I hope this I have satisfied our question.
Questions from the floor? From our visitors from Malaysia, sir? You have sir,
Sorry,
go ahead, please.
I have some question about the recruitment assessment, recruitability assessment. We have a lot of methods to assess recruitability assessment, such as PV gentle suit lung and patient and patient index, right? So do you have any recommend which method is benefit for which patient, or should be aware of to use method in which patient?
Okay. This is a very difficult question. Okay, very difficult, a very important one. Let's see if we can come with some intuition. 1 second. I don't know if you are familiar with these histograms from CT. So in the x-axis, you have the Hounsfield units. 0 means collapse, minus 900 means overdistension. Okay? So this is the histogram. So for instance, this blue lung has lots of collapse. So you have a peak of density, peak of units at 0 density, which means complete collapse. So this animal was at a PEEP of 15. Okay? Then I applied the recruiting maneuver, and then we had this shift. All these above this threshold is the threshold of recruitment. Okay? So when the unit has more air, the aeration is closer. Oh, thank you. It's closer to above. It's to the left, right? So you go to minus 200, minus 400. Here is the normal lung, right? So these units now shifted to these units. When this happened, so these units suffered this shift. You have now look at me. So you have one alveoli that was completely like this, and then it got inflated to minus 400 maximum. So it goes like this. So this is the ideal position to have a very good compliance. But the gain in volume is not that big. So the unit is just like this. Okay, now let's imagine this situation, that I had a little bit of collapse in blue, and then I applied a recruiting maneuver, and then my units jumped to this. Okay? So when this happened, now look at me again. So now you had complete collapse, but now it's boom. Because you are working at high pressure, and these units get completely overdistended already with a high volume. In this case, you gain a lot of volume, but very little compliance, because the units jump from low compliance because they are collapsed to low compliance because they are overdistended. It's a boom, complete jump. So the key question is that for most patients, how it happens, right? And this is why we believe that it's very tricky to use jumping volume to assess recruitability. Because really what the key question is that as I gave you an example, the better the compliance, the more normal is the lung, the bigger is going to be this jumping volume, and then you have a gigantic gain in volume and maybe little recruitment. Okay, so now let's think about the philosophy of each method. if you are using a PV loop and you are measuring hysteresis in the PV loop, you are basically measuring the vertical distance between the inflation limb and the expiratory limb. This is a gaining volume. So PV loop is gaining volume and is subject to this error. Okay, it's subject to this error. Recruitment to inflation ratio is based on gaining volume. Let's record. Do you want me to record how is measured the recruitment to inflation ratio? Okay, so let's go. Tip of 6. So this is the maneuver proposed by Laurent Brochard and Lu Chen. Okay, published in the Blue Journal. You are at a PEEP of 6. You jump to 16. You have to decrease the respiratory rate to not have auto PEEP, and then you suddenly drop back to 6. So this is the sequence. And I'm showing here the EIT signal together, right? Okay, then how it works. First of all, you concentrate at this part of the curve when you are jumping down from 60 to 6. You have to work at a low respiratory rate to avoid auto PEEP. Then let's suppose that, okay, by definition, I'm dropping 10 centimeters of PEEP. And let's suppose that I'm measuring here in the EIT. Typically, you don't have the EIT, but I'm using EIT because it gets more intuitive. And then I measure that the change in end expiratory lung volume is 1,000 mLs from here to here. Okay, that's it. But when I measure compliance, compliance was 30. I measure compliance here during tidal breaths. Compliance was 30. So the expected change in end expiratory lung volume should be just 300 mLs because it's 30 of compliance times 10 centimeters of water. So this end expiratory lung volume change should be only 300, but I had 1,000. So the observed one, the expected was 300, but the observed was 1,000. So the recruited volume is 700. Now you understand that is a change in volume, which is subject to these kind of errors of, you never know if a unit is recruited and doing boom, or it's just having, is recruited to a good status. And then, so the recruitment to inflation ratio and the hysteresis of a PV loop, everything is based on volume. And then I believe that we have data to show that they are less reliable than a change in compliance. Okay, so that's it. So I prefer changing compliance, and ideally I prefer using EIT, if possible, yeah.
This question goes, can one use PO1 as an estimate of occlusion pressure?
Good point. The P.1 is, let me see if I have a good example. No, I don't have here, but let's try to explain theoretically. So basically, you can measure the P.1 exactly in the same maneuver, in the same breath that you are measuring P occlusion, right? So because when you do P occlusion, you are, let's suppose that my finger is representing the airway pressures. You are just to trigger about to trigger the ventilator, doing a small inflection in pressure, but then you clack. You close inspiratory and expiratory limbs of the ventilator, and then instead of having this tiny drop in airway pressure to trigger the ventilator, you go to do, and you have the occlusion pressure, right? So if I take just the first 100 milliseconds, I can measure the P.1, And if I take the whole maneuver, I measure the occlusion pressure. And typically what we have seen is that when the patient has ICU acquired weakness, he can perform this first drop perfectly. But then, this is my normal patient, and my patient with acquired weakness, he can do the first part of the breath and then he stops here and then he starts to... So he has a short version of the normal occlusion pressure. So his P.1 is exactly the same as the normal patient, but the P occlusion is completely different. So the P.1 was a maneuver designed to estimate how much the central nervous system is firing the diaphragm. And this is almost true, except when you have such a degree of acquired weakness that he cannot even perform well in the first 100 milliseconds. But you really need an extreme case of weakness to impair the P.1. But the P occlusion, no. P occlusion, any mild degree of acquired weakness is going to compromise your P occlusion. When we are doing lung protection, I prefer to see and to measure the final result of the muscle activity. So I'm not a physiologist interested in knowing the ventilatory drive. So I prefer to measure P occlusion, because then it's the pressure that is going to damage the lung. And the interesting thing for the latest years is that they could show now that a high P occlusion is bad not only for the lung, but also for the diaphragm. They have measured, and I saw now in Japan. I just came from Kyoto and Osaka, and the people from Osaka University, they have a beautiful study in which they showed that animals with a high P occlusion, they have edema, apoptosis, and neutrophil infiltration in the diaphragm, and also they develop less force. So a high P occlusion is causing damage not only to the lung, but also for the diaphragm. And this is something that you cannot measure with P.1. I think we don't have a good correlation.
One more question was asked and said, please explain more on the use of NIF.
Okay, the NIF is, it took me a while to realize how to get to use this trick. Is in ventilators in which we cannot you don't have the inspiratory pause and expiratory pause. And remember that the expiratory pause looks a very simple maneuver, but it's a very smart maneuver, because the ventilator is waiting for the triggering time, and then he performs the occlusion. He cannot close the valves before or afterwards. He has to close exactly, boom, when you have the trigger detection. So it's a very synchronized maneuver. And this is why only the modern ventilators, they can do it. So then you block the inspiratory and expiratory circuit of the ventilator. And so ideally, I think the ventilator should have an expiratory pause, and that's it. But in the PB, they didn't think about this when they designed. And then you have to go to negative inspiratory force maneuver. So it's if I remember correctly, it's in special maneuvers menu, and then you can do NIF, or you can do some other measurements that I don't remember. There are 4 items, and one of them is NIF. And then there it's possible, but that maneuver was designed to. Initially, they thought this was a maneuver used for weaning failure, so that you want to understand which is the maximum force developed by the diaphragm, right? And then you can use this maneuver, but take only the first cycle, not the second or the third or the fourth, like we use for assessing maximum inspiratory pressure. Because typically, when you want to access maximum force of that the patient has for weaning, you wait until because the second attempt, the patient does a larger force, larger, and then it stabilizes. And then typically this requires 5 to 6 cycles, and then you have a stable maximum inspiratory pressure. This is not the case. We do it, but we use only the first cycle. That's it.
Any more questions from the rest of
Again, this is the recruitment maneuver like we are proposing in the ventilator. So you typically use a pressure control, and then the machine goes automatically increasing PEEP and then decreasing PEEP. You can choose something very comfortable. Nowadays, when I go to let's say to a place where people is extremely careful about overdistension, I say, okay, so establish a maximum ceiling point of 30 of pressure, but typically I suggest to go at to a minimum of 35, because I never saw any case of barotrauma with 35 or 40 of pressures in the airways. So I think you can go, and you are going to stay here just for a few breaths. But this is the maneuver, and this is what you see in the EIT. And look how interesting is this. Look at this. So I started at a PEEP of 10. So here I have a PEEP of 15, right? And this is the FRC, or end expiratory lung volume, at a PEEP of 15. Now I'm back to 15 here. Sorry, 15 here. So 15 here, 15 here. Let's check what is happening. First, I have a recruited volume here, but I'm not interested in the recruited volume. What I'm interested is in checking this amplitude, because this amplitude divided by this pressure is giving you compliance. And this is very interesting because it looks simple, but it's not. When I talked with Laurent Brochard for the last 10 years, he's always telling me, compliance is not good to assess recruitment. Why? Because he was increasing PEEP from 6 to 16, and then he observed that in most patients, even the very recruitable ones, compliance deteriorates or just stays the same. So from 6 to 16, even in patients that have very large recruitment, compliance was the same. But then he never thought, he never think about something very smart in this maneuver. When you are increasing from 6 to 16, you are increasing recruitment. Many units may be recruited, and many units are going to be overdistended. And then from 6 to 16, maybe the net result is uneven compliance. But maybe you had a lot of recruitment together with a lot of overdistension. When we use this maneuver, we avoid this problem completely, because we are measuring the gain in compliance at the same PEEP. So you take out overdistension of the game. Because I'm going to measure at the same PEEP this compliance and this compliance. So I don't have any overdistension here. And then this is why this tidal volume is larger, because now I have the pure effect of recruitment without having any overdistension. And this is why with this maneuver we get a very specific result. It's just for you to understand why I believe that, and important to keep in mind, because many people believe that compliance doesn't work for assessing recruitment, and this is absolutely not the case. And I can show you that we have just to show you one final slide. When we use in this way, look how good is the correlation with CT data. Compliance gain at the same PEEP because we want to avoid overextension, and how much you reverse collapse on the CT. So this result was very well. If I try to do the same correlation with volume gain, forget. That's it.
Thank you, sir, for that additional information. It really helps. So, at this juncture, I would like to thank everyone, of course, our partner IDS, to each partner in the individual countries, PT Indomedic, Gemilang Asia, and Nippon, to the rest of our distributors. Thank you so much. Thank you so much, dear doctors. We really mean our business. That's why we're providing clinically relevant solutions that matter. And hopefully in the future you'll get to know more about this, and we will definitely get in touch with you. In my language, maraming salamat. Salamat datang. Thank you so much for your presence, and we really appreciate everything.
ค่ะในนามของบริษัท IDS Medical System ประเทศไทยจำกัดนะคะวันนี้ขอกราบขอบพระคุณอาจารย์ผู้ทรงเกียรติทุกคนนะคะที่กรุณาสละเวลาอันมีค่ามาร่วมเรียนหนังสือกับเรานะคะแอนดีใจมากๆที่ได้พบอาจารย์ระดับสูงๆทุกท่านเลยวันนี้เป็นเกียรติอย่างยิ่งแล้วก็ขอกราบขอบพระคุณอาจารย์กล้วยไม้ด้วยนะคะที่กรุณามาเป็นเกียรตินะคะแชร์ประสบการณ์เรื่อง Gentle หลังสูตรนะคะ and thank you so much Dr. Amato we really appreciate your presence in Thailand and we hope that you can come more often so thank you ขอบพระคุณทุกท่านค่ะ